Good evening, everyone. My name is Michelle Oana, and I'm the Associate Director of Development and Communications at Myeloma Canada. I would like to welcome you to our very first English educational webinar this evening on the highlights from the ASH conference, which was held in December of 2016. For those of you who speak French, we hosted our first webinar just over 2 weeks ago, which was presented by Dr. Julie Cote from the Centre Hospitalier Universitaire de Québec. So if you'd like to have a peek, you can find the recording of this presentation on Myeloma Canada's YouTube channel. Just a reminder that you will be able to type out your questions at any time during this presentation using the questions function on your GoToWebinar panel on your computer screen. We will get to your questions at the end of the presentation, so not to worry. Again, just a reminder that this presentation will be recorded and uploaded to our YouTube channel tomorrow. So if you miss anything or you would like to rewatch, that option will be available to you as well. So without further ado, I'd like to present to you Dr. Arlie McCurdy, Disease Site Lead for Multiple Myeloma at the Ottawa General Hospital and Assistant Professor at the University of Ottawa. We are very pleased to have Dr. McCurdy join us this evening to share with us all of the exciting developments from the 2016 ASH conference. I will now pass over the mic to Dr. McCurdy. So hello, just want to make sure that your mic is working.
Hi, sounds good to me. You're
perfect.
Perfect. Okay, so hi everybody. This is a bit different for me. So I'm alone in my office and I'll have to laugh at my own jokes and my own hand gestures because I can't see any of you. But hopefully we'll have time for some questions at the end, or I'll make sure to leave some, and hopefully get something out of this presentation. Let me just make sure this works. There we go. So I just had a few objectives for tonight, and I was hoping to go through just a little bit of background in terms of some of the terminology that we use in myeloma and the different stages of treatment, because it's gotten a lot more complicated in the last few years. And the other thing is that I'm sure there's people out there tonight who are new in the course of their illness or treatment, and there's probably some veterans out there who have been going through various treatments for the last 10 years. And so hopefully that can get us to some common ground. And then I was going to go through some of the highlights from the ASH meeting in December, in particular focus on developments in newly diagnosed patients and the importance of stem cell transplant. Talk a bit about maintenance therapy. That's been something that's been quite hot in myeloma for the last few years. Review a little bit on minimal residual disease, and we'll talk more about that. And then talk about some of the new options for relapsed or refractory patients and some of the new treatments that are coming out. And then we'll have some time for questions at the end. I think overall, what I'm really hoping is that everybody can learn something from this webinar, but also the overall message should be one of hope and promise and excitement, because there has never been a time that that there's been more rapid development in myeloma, and I think that's something we can all be happy about. So just to review so quickly, myeloma is not as rare as many people think. It's about 1% of all cancers and about 10% of blood cancers. And the risk is about 4 in 100,000. So in a city like Ottawa, we see about 100 new cases of myeloma per year. On average, people are in their 60s, and the vast majority of patients are greater than 50 years old, although the youngest person I've seen was 26 and the oldest is 98. And so it does affect people of all ages. Myeloma is more common in men, about 1.5 times, and more common in the Black population. And the risk is slightly higher if you have a first-degree relative who also has myeloma. However, the vast majority of patients really have no family history at all. And what happens in multiple myeloma, and I think you'll be able to see my pointer here, is in the normal bone marrow, there's a whole bunch of different types of blood cells, and all these bigger ones that have various colors are what are called white blood cells. And those are really your immune system. And in myeloma, you get too many of these big blue cells, and those are called plasma cells. And in this big blue part, they make extra antibodies. And if I knew how we went from here to here, I would be very famous. But we do have some understanding of how myeloma happens. We know that these plasma cells are responsible for making antibodies, and this is what an antibody looks like under a microscope. And the first thing that happens is you get something called MGUS, or monoclonal gammopathy, And something happens to those plasma cells where rather than making an antibody in response to some sort of stimulus, they get turned on and start to make extra antibodies for no reason at all. And we think that there's probably some sort of predisposition that patients have, but no one knows why. There's then a second step that happens. So these initial genetic changes are necessary but not sufficient, meaning most patients who have MGUS don't go on to develop myeloma. There's a second hit that happens. And when that happens, you get the production of lots and lots of these antibodies and more of these protein-producing cells, and that's what makes the diagnosis of myeloma. And to actually have a diagnosis, you do need a biopsy. So many patients, or most patients, will have had a bone marrow biopsy. And what we see in the bone marrow are these increased plasma cells. But that in and of itself isn't enough to diagnose myeloma. We also need evidence that those are causing some sort of harm. And the classic, what's called the CRAB criteria, are that there's high calcium, kidney failure, or renal insufficiency as it's also called, anemia, which is low blood count, or bone lesions. And more recently, in the last couple of years, the International Myeloma Working Group has updated the definition to include some other markers that we know really increase the risk of patients developing myeloma. So people who have lots of plasma cells and don't necessarily have organ damage, but have really high numbers of plasma cells, high numbers of light chains, or spots on an MRI, greater than one spot, we know that there's about a 90% chance that they go on to develop this end organ damage. And so these patients in the modern era are treated also as multiple myeloma. The big divide in multiple myeloma treatment really is, and in newly diagnosed patients, is really there's a distinction between patients who are eligible for high-dose therapy and a stem cell transplant, and patients who are ineligible for stem cell transplant. And in Canada and most of North America and Europe, that's typically age around 70. Once you start to get above 70, the risks of complications from high-dose therapy go up. And you also need to be fit. So physiologically around age 70 or less and in quite good shape to go on for a transplant. Whereas if that's not the case, the patients would be considered ineligible for transplant. And this is a big divide with respect to treatment. I think also just in preparation for some of the new studies we're going to look at tonight, I wanted to go over how myeloma is actually treated in Canada. And so if we take newly diagnosed patients, we divide patients into patients eligible for transplant and ineligible for transplant. And in the transplant eligible group, patients are treated with bortezomib or Velcade-based treatment as their induction. And we talk about induction treatment. This is what we're talking about. Most places that's Cy/Bor-D, so combination with cyclophosphamide and dexamethasone, but there are some centers or some provinces that have access to lenalidomide in the setting. That's followed by an autologous stem cell transplant, followed by lenalidomide maintenance in most patients, or at least consideration of lenalidomide maintenance in most patients. At the time of relapse, most patients are treated with lenalidomide or Revlimid in combinations. And at the time of next relapse, they're treated with pomalidomide in combinations. In patients who are ineligible for transplantation, they also have bortezomib-based therapy, but typically that's combined with melphalan in the form of MPV or VMP for 9 cycles or 36 weeks, or in some centers, Cy/Bor-D, much like these patients, just a prolonged course. Patients then are not treated with maintenance therapy and they're actually off of treatment after the completion, provided they're in remission. And at the time of relapse, lenalidomide in combination, so with dexamethasone or other agents, is started. And at the time of subsequent relapse, it's pomalidomide combinations. So when we talk about some of the things tonight, we're going to talk about treatment for newly diagnosed patients in the induction setting, which is bortezomib-based treatment. We're going to talk about some of the advances in stem cell transplant, some of the advances in maintenance, and then spend a bit of time talking about what is happening in relapsed and refractory myeloma and some of the new treatments that are coming. Hopefully that makes sense. I wanted to just provide also a few definitions in case there's some confusion. We tend to use some of these terms interchangeably, but these are essentially the generic names for the drugs that we talk about, and these are the trade names. So bortezomib is Velcade, lenalidomide is Revlimid, pomalidomide is Pomalyst, carfilzomib is also Kyprolis, and daratumumab, which is new, is Darzalex. And in terms of the disease and the study terms, this is another thing that terms that we throw around, but it's important to define. We use something called progression-free survival in myeloma quite a bit. And that is the time from diagnosis or treatment to the time of relapse. So basically the amount of time the patient is in remission. And that's different than overall survival. You may have various different PFS intervals or time in remission in the course of myeloma. Survival is the time from diagnosis to the time of end of life. The median is a little bit different than the average. It basically means the point at which half of patients have reached an outcome, whether that's progression-free survival or overall survival. And then MRD, which is one of the new kids on the block, is a minimal residual disease. And that's looking at patients who are in remission and may have quite deep remissions with our conventional ways of measuring protein in the blood. But there's some new techniques that actually take that to the next level and look at a really, really tiny amounts of myeloma that are left in the bone marrow. So like Michelle said before, this will be available and recorded if you want to refer back to some of these definitions down the road or later to help clarify some of the talk. So I'll tell you now and move on to some of the highlights from ASH of 2016. So this was in sunny San Diego, which has been beautiful every time I'm there. The ASH meeting moves essentially between 4 cities, so it's in San Diego every 4 to 5 years. It's a really big meeting, so it happens over 4 to 5 days. There's greater than 27,000 people there who are studying blood disorders of all types. And myeloma has been very prominent in the last few years. And in fact, it was the only sessions I saw this year where there was lineups at the door and people weren't able to actually get into all of the presentations. They had overflow rooms. Just to put an idea of scope, there was over 800 abstracts, so research projects that were presented that were either directly about multiple myeloma or involved patients with multiple myeloma. Over 200 of these were oral presentations and over 600 posters. And you know, if you think about one of these presentations is about 10 minutes, and that's about 8,600 minutes or 150 hours of talking about myeloma over these days. And so it's impossible to summarize all of this, but I'm hoping to go through some of the major themes that were talked about. And just a plug for us here in Canada, there were many Canadian presentations and contributions, and many from members of the MCRN or the Myeloma Canada Research Network, which of course is very closely connected with Myeloma Canada. And so we were able to show quite a bit of Canadian pride at ASH this year. So moving on to some of the meat or the new stuff that happened at ASH, I thought we'd first talk about newly diagnosed multiple myeloma. And I wanted to go through about 3 abstracts for each of the categories that I mentioned before to illustrate some of these paradigms that are changing. Bear with me, I know this slide looks really busy, but I will walk you through it. And this slide you actually will get familiar with because I talk about the 3 different parts of it at 3 different times during the presentation. This is a study of the Myeloma 11 study, which is out of the United Kingdom, and it was actually almost 600 patients. And this is a very interesting study because it's really the first randomized trial that looked at something called response-adapted treatment. And we've talked a lot in the past about risk-adapted treatment, so treating high-risk patients perhaps differently in myeloma, with the asterisks of it's difficult to do that in our current public paying healthcare system. But we know that individual or tailored therapy is important. So what the study was designed to do was to look at patients to see if you gave them more intense treatment that the remissions would be better. So what they did is they took all patients with newly diagnosed myeloma and included both transplant and ineligible transplant patients. And the first randomization was actually to 2 different groups, cyclophosphamide, Revlimid, and dexamethasone versus cyclophosphamide, thalidomide, and dexamethasone. And those patients had a minimum of 4 cycles of treatment, and then they checked what the response was. This is where the interesting part is in this study, and this is what this abstract looked like, was the second randomization. So after this initial treatment, if the patients did not have a good response to treatment, so not at least a 90% reduction in their protein, they went on to have additional treatment with Cyborg-D, that includes Velcade, to the best response possible. So it's taking your initial treatment and then making it more aggressive by adding more treatment. And from that point on, the patients who were eligible went on to have a transplant. The patients who weren't went on to have no further treatment. And then everybody was randomized again to Revlimid maintenance or observation. So I know that's a little bit muddy, but it's the 3 different points. And the important part for this abstract is this piece here, where patients who didn't have a great response here were randomized to additional treatment to get a deeper response before their transplant. And in fact, it did show a benefit. So we know that using additional treatment significantly improved the progression-free survival, so how long the remission was, from a median of 24 to 30 months in all patients. But this was primarily seen in the transplant patients. So folks who didn't have at least a 90% reduction in M protein before a transplant had more treatment, and that improved their remission after transplant from 31 to 55 months. It was only 14 months compared to 20 in the transplant ineligible patients, so this is where the bulk of the benefit was seen. And that we also saw deeper response rates in the Cyborg-D group, which is in many cases been shown to be a proxy of overall survival. So what this paper tells us is that there is likely a role for response adaptive therapy, but remembering this is one study and it's early stages. However, there's likely a role for response adaptive therapy. The second study I wanted to talk about for newly diagnosed patients in the setting of transplant was a European study which included about 1,500 patients. And this was done in Italy and Greece and the Czech Republic and the Netherlands. And this really actually supports what our standard of care is, which is doing a stem cell transplant up front. One of the rationales for doing a study like this is that in the era of new treatments, so things like Revlimid and Velcade and pomalidomide, the utility or the value of autologous stem cell transplant, which is relatively old therapy, has been questioned. And so what this trial did is took patients who had newly diagnosed multiple myeloma who had Cyborg-D induction, much like you would have in Canada, and they were randomized to having 4 additional cycles of Velcade-based therapy, so VMP is very similar to Cyborg-D, versus autologous stem cell transplant, and that depended on the center. They had 1 or 2 transplants. And that was the purpose of this abstract, was to look at this difference. If you had a transplant versus you had just more chemotherapy, was there a difference in the remission? This study I'll talk about again later because there was a second randomization looking at the maintenance arms, but the purpose of this abstract was actually to look at this part. And what we see here is that there is longer remissions seen with autologous stem cell transplant as compared to no transplant in patients treated with Cyborg-D. And at 3 years, a higher percentage of patients were still in remission after a transplant. And that lends support and a randomized trial to our standard of care here in Canada. And again, I'll talk a little bit more about this part later. The last study in newly diagnosed patients I wanted to highlight was a final analysis of the first trial, and this is actually for patients who are ineligible for stem cell transplant. The first trial was a large study, I don't remember off the top of my head, but over 1,000 patients who had newly diagnosed transplant ineligible myeloma and were then randomized to RD, which is lenalidomide or Revlimid and dexamethasone, continuously until progression, compared to lenalidomide and dexamethasone for 18 months, compared to melphalan, prednisone, and thalidomide, which was the comparator arm. I should note that both of these treatment arms were 72 weeks long. And what the authors looked for was difference in progression-free survival and then in overall survival. This is a really important trial to think about in Canada because lenalidomide and dexamethasone is coming for newly diagnosed patients who are transplant ineligible, and in fact is funded in some provinces. It's a little bit difficult because in our standard here is VMP, which basically replaces the thalidomide with Velcade. But the remissions that we see with MPT are relatively comparable. This was quite an interesting result. So we saw that in RD continuous, so continuing lenalidomide until progression, resulted in longer remission, so longer PFS, as compared to the Revlimid for 18 months or the MPT. But in the overall survival group, we see that the RD continuous was better or longer than MPT, so 60 months or 59 months versus 49. But in fact, the 18-month looks as though it's just as good, if not a bit better. One of the challenges here is that the study was not powered, meaning there weren't enough patients to actually prove that there was a difference between these two. It was actually powered to compare this arm with this arm. And so it's very hard for us to draw any conclusions here in terms of whether or not RD continuous is truly better. The author's conclusion is that it shows a prolonged progression-free survival compared to these two arms, and that it prolongs overall survival to this arm. And they maintain that RD continuous is a standard of care for transplant-ineligible patients, and that is how the recommendation is coming through in Canada. So this will be a new standard of care for us in the near future. And this study was published, at least the PFS data was published last year in the New England Journal. So I wanted to switch gears a little bit and talk about maintenance treatment. Some definitions are important in this area. Maintenance is continuous, relatively low-dose chemotherapy from the time of treatment completion until the time of progression. It's often confused with something called consolidation therapy, which is a shorter course of treatment immediately following therapy. So for example, after a stem cell transplant, maintenance Revlimid would be starting Revlimid 10 milligrams a day about 3 months after the transplant, continuing until progression, whereas Revlimid consolidation would be 2 months of higher dose Revlimid followed by nothing or observation until progression. And there were some really interesting studies this year that looked at the role of maintenance. This slide probably looks familiar. So this was the patients who, again, in the big UK study, were randomized to 2 different inductions. We talked about before how they were randomized to more treatment if they didn't have a good response. And then there was a third randomization for all patients to lenalidomide maintenance versus observation. And this included everybody in the trial. So patients who had transplants and also patients here who were not eligible for transplant. Everybody was randomized to observation or lenalidomide maintenance. And they did see a significant difference in this randomized trial. In patients who went on to have a transplant, the median progression-free survival in the patients who had lenalidomide maintenance was 60 months or 5 years as compared to 28 months. The benefit was there but smaller in the transplant ineligible patients, 26 versus 12 months. And so in this randomized setting, keeping in mind that these patients had risk-adapted therapy up front, we see that there is a benefit in lenalidomide maintenance of patients who have had a transplant as well as patients who have not had a transplant. And this was independent across all of the risk groups, so different cytogenetic groups and such. I think it's important to mention that about 20% of people had to stop lenalidomide because of toxicity, so about 1 in 5. And there was a slightly increased risk of second primary cancers in the lenalidomide group, so they had 48 cancers versus 24. But overall, because the risk of progression was less, it's hard to know what the significance of that is. This study also likely looks familiar. This is the big European study again, and we talked previously about the randomization in newly diagnosed patients to either a transplant versus more chemotherapy. This abstract actually looked at the second randomization. So patients in this study, after they had their transplant or more chemotherapy, they were randomized to have either 2 additional cycles of VRD consolidation, so higher dose, followed by lenalidomide maintenance, or no consolidation followed by lenalidomide maintenance. And what we did see is that the 3-year progression-free survival was quite similar between the two groups, a little bit better in VRD, 65 versus 60% here, but the overall survival was quite similar, at least with 3-year follow-up at 86 or 87%. So the conclusions of this study were that consolidation with VRD followed by lenalidomide maintenance shows promising results compared to maintenance alone, but further follow-up study is required to know what the true benefit will be. And the last study I wanted to mention in maintenance was the Stamina trial. And this was actually a late-breaking abstract. So at ASH, on the final morning of the conference, they have selected abstracts that were submitted. And these are typically excellent abstracts. All the abstracts are excellent. I shouldn't discriminate, but these are typically excellent abstracts. And this was one of them this year. And this is a very important study. And really does validate the standard approach now. So this is a BMT-CTN group, so a large American study of about 750 patients. And they took patients who had newly diagnosed multiple myeloma and were eligible for transplant. And all of those patients were, so the patients coming in here were newly diagnosed within 12 months of treatment. And most of them had Cyborg induction or something similar. Those patients were then randomized to an autologous stem cell transplant followed by VRD consolidation, a tandem, which means 2 autologous stem cell transplants, or a single autologous transplant, all followed by lenalidomide maintenance. And so our standard care is typically auto-transplant lenalidomide maintenance. These are more aggressive chemotherapy routes or more aggressive routes. The interesting thing here is that there, at 38 months follow-up, there is no difference in progression-free survival and no difference in overall survival. And so that's really important because, predictably, we don't have a lot of data because this is an abstract, but predictably, number one, this is a standard care. Certainly it costs less and is likely less toxic than the other arms that are more aggressive. The conclusions here is that the addition of RVD consolidation or a second transplant was not superior to single auto transplant followed by lenalidomide maintenance. And so this would remain the standard of care until further study is done. So move on to minimal residual disease. And this is certainly an emerging area and one where there's a lot of active research going on. And like I mentioned in the introduction, minimal residual disease is a way of looking at very small amounts of myeloma disease that sometimes escapes measure by our traditional ways of testing, which is looking for levels of protein in the blood or cells in the bone marrow that we can see under the microscope. And this was an abstract presented by Dr. Susanna Barr from the US. And they looked at 100 different patients at various time points throughout the illness. And the important thing here is they looked at different ways of looking for MRD. So the 3 ways that we look at that are something called multi-parameter flow cytometry or multicolor flow cytometry. And this is what happens in flow cytometry is essentially cells go through a tube and different beams of light shine on them and they glow. And that's able to pick up 1 myeloma cell in 10 to the 5. So you can imagine that's a lot more sensitive than looking under a microscope. They also did next generation sequencing, which is looking at DNA using a technology called clonoSEQ. And that's similar but a little bit more sensitive, that can pick up 1 in 10 to the 6 cells. And then they also did PET-CT imaging, and this is where we use FDG or glucose to look for bone lesions. And it might seem a bit silly to take pictures when we're talking about these tiny, very specific or very microscopic ways of looking at cells. But the bone marrow is very patchy. And so, meaning that you could do a bone marrow biopsy and send a sample for either of these measures and miss it and be in an area where there's complete remission. And on a PET-CT scan, you could actually see areas of disease. And so likely a combination of these measures will be used in the future to look at MRD. I think it's important to note that this is experimental at this time. We are moving towards MRD-directed therapy, but it's not readily available in the vast majority of centers. The interesting thing in these patients is that the vast majority, sorry, I shouldn't say the vast majority, the proportion of patients who are MRD negative increased with treatment, and it was the deepest in maintenance. So the more treatment patients had, the higher chance they had of getting to an MRD negative status. But over half of patients remained MRD positive at the end of treatment. And so again, we're still working on how to best use this technology. Relapsed patients, as I mentioned before, can present with focal lesions alone. And so you may have be MRD negative by these two parameters and still see abnormalities on PET-CT. When we look at clinical trials, again, this familiar looking slide, they were also looking at MRD. So it was a third abstract from the Myeloma 11 trial. And in many of these patients, they were able to evaluate MRD by flow cytometry. And so they looked in this abstract specifically at the patients we've talked about before who were randomized to one of these two arms, more intense therapy, and then if eligible had a transplant. There was also patients who were randomized here, more intense therapy, who were not eligible for transplant. And in this trial, they looked at the MRD status in patients who were transplant ineligible, so that go down this line. 13% of those patients achieved negative MRD status. And the important thing here is that that was strongly predicted with improved progression-free survival, meaning the patients who had deeper responses had longer remissions, so 34 versus 18 months. So we see confirmation here that this is a powerful predictor of outcome. This slide is going to make a lot more sense in a couple of minutes, and the reason being that there was updates of these two trials called Castor and Pollux, but I wanted to just touch briefly on them in the MRD setting. Castor and Pollux, they're actually named after constellations. I didn't know that at first, but they look at combinations of daratumumab with either bortezomib or Velcade and dexamethasone in the Castor trial as compared to Velcade and dexamethasone alone, or daratumumab in combination with Revlimid and dexamethasone in the Pollux trial as compared to Revlimid and dexamethasone alone. And as I'll talk about in the upcoming slides, the addition of daratumumab to these backbones results in impressive differences in progression-free survival, very well tolerated, and certainly likely to be one of the most promising drugs we have in myeloma going forward. For the purposes of looking at MRD, these curves actually separate the patients who were MRD positive versus the patients who were MRD negative. And on these on these charts, I should say, this is the amount of time patients were in remission in months, and this is the percentage of patients who are progression-free and alive. So the good line is the top line. And in both of these studies, daratumumab Revdex versus Revdex, or daratumumab Velcade Dex versus Veldex, we see that the patients who were MRD negative do better. So they have longer remissions in both of these trials. Moving on, we have about 10-15 minutes left. I wanted to talk about some of the exciting developments in relapsed myeloma and the new therapies that are coming. And as mentioned, daratumumab is becoming front and center in myeloma. So daratumumab is very interesting. It's a monoclonal antibody, which is against CD38. And so basically it binds to the abnormal myeloma cells. And the Pollux trial was actually previously published in the New England Journal of Medicine at the end of last year, but it's a randomized phase 3 trial of daratumumab with lenalidomide and dexamethasone versus lenalidomide and dexamethasone, and improved progression-free survival significantly. So in the last follow-up, the PFS was not yet reached in the daratumumab RevDex versus the RevDex alone arm. This is particularly relevant in Canada, where the vast majority of centers or provinces have lenalidomide dexamethasone, so the standard arm here in the trial, as their standard of care for relapsed myeloma. The overall response rates are 96%, which is unprecedented in relapsed myeloma. And the update at ASH really was that the longer PFS and higher response rates was maintained regardless of whether the patients were previously treated refractory or bortezomib. And they weren't able to separate that out quite yet for patients who were previously treated with lenalidomide. But I wanted to share this again because of this here, the long remissions and the impressive response rates. I should also mention that daratumumab is very, very well tolerated, so there are some reactions as the drug goes in, but the vast majority of patients do exceedingly well. The CASTOR trial is very, very similar. So again, it's daratumumab, the antibody, combined with bortezomib and dexamethasone versus bortezomib and dexamethasone alone. The progression-free survival not yet reached in the experimental arm versus 7 months, with overall response rates of 84%. And again, that's quite unprecedented in this group. And regardless of whether you had 1, 2, or 3 prior treatments, this benefit was maintained. So these are very important, and we're hoping lead to access to daratumumab for our patients in the near future. Right now, it's available on a compassionate program from the company and in the setting of clinical trials. I wanted to share this slide because I think it provides a good frame of reference for where we are going with the new combinations of medicines in relapsed myeloma. So again, in most patients in a Canadian setting, the standard care for first relapse is Revlimid dexamethasone, or RD. In the subset of patients who may have had Revlimid up front, the standard would likely be bortezomib or Velcade and dexamethasone, or a combination thereof. These are the big trials that have looked at new agents in combination with those backbones over the last couple of years. And you can tell the impact. They're all published at the bottom here, or the references are all here, looking at, these are our big journals in medicine, so the New England Journal of Medicine and Lancet Oncology. And so these are available for review if people are interested. The ASPIRE trial, if you look at adding carfilzomib, that's the K, to the Revlimid backbone, which is our standard care, increases your overall response rate to 87%, and the progression-free survival to 26 months as compared to the standard 18, so over 2 years. And that really, as of now, is the longest PFS, but we'll see what happens in the final report of the Pollux trial down here. The Endeavour study I included because it involves carfilzomib, the K here, with K is for Kyprolis, same thing. And that is compared to Velcade in the relapse setting, and we see these impressive overall response rates, and again, double the remission. And the carfilzomib is actively coming in the Canadian pipeline. Lots of access on clinical trials, but also should be readily available soon. The Tourmaline trial looked at ixazomib, which is a pill version of a proteasome inhibitor, so similar to Velcade and carfilzomib. And we see again, when you add that to our standard backbone, you increase the response and you increase how long the remission is. Eloquent is elotuzumab, which is a monoclonal antibody, again added to a backbone, improves the response and improves the PFS. This is unlikely to make a resurgence in the Canadian market, I think mostly due to a marketing decision, but the direct competition here is daratumumab. And then CASTOR and Pollux, as we mentioned, both published last year in the New England Journal. In combination with Velcade, the daratumumab increases the response rates to 80%. We have not reached the median progression-free survival. And in daratumumab RevDex, the response rate's greater than 90%, and we haven't reached yet. So these are the trials that are driving how therapy is evolving now in relapse patients. There was a couple of winners, I think, at ASH in terms of new treatments. So things that are a little bit earlier in the pipeline than daratumumab, but exciting drugs that are coming forward. And one of them, there's a bit of a Canadian bend to this story, and that's selinexor. So I wanted to share two abstracts with you about selinexor. So selinexor works in various ways, but it's an oral medication that suppresses tumor proteins and has shown promise in myeloma cells. And the first study presented by Dr. Vogel was a phase 2 study. That means everybody had access to the drug. And this was selinexor in patients who were called quad refractory. So these are pretty heavily pretreated patients who had been exposed to Velcade, carfilzomib, lenalidomide, Pomalyst, and another group of patients who were penta refractory, meaning all of those four things plus daratumumab or an antibody. They were treated with selinexor and dexamethasone, and on average, or the median, was 7 prior treatments. The response rates were 21%, so that's actually quite impressive. I know it doesn't look impressive compared to our last slide, but if you think about having 7 prior treatments and still having a chance of responding, that's quite good. One of the challenges seen with selinexor in this study was toxicity. And so there was quite a bit of nausea and anorexia and weight loss in patients, such that in the next trial I'm going to present, they had actually suggested involving a dietitian. And so obviously tolerability and quality of life is really important. So we were hoping in other studies of selinexor that would be the case, it would be better tolerated. And that's what happened, actually. So the other selinexor study I wanted to mention is the STOMP study. And this is another chance to plug Myeloma Canada. So this was a Canadian study led by Dr. Bayless in Calgary. And this is, so a Canadian, I should mention, a Myeloma Canada Research Network study. This is looking at selinexor in combination with bortezomib or Velcade in refractory patients. And it's a small trial, phase 1b and 2, so looking for safety and then moving on to efficacy. These patients were quite heavily pretreated as well, so on average or a median of 4 prior treatments. The range there, so some patients up to 12. But the overall response rate here is close to 80%, and that's quite impressive in patients who have had 4 prior treatments. And even patients who were previously refractory to a proteasome inhibitor, so something like Velcade, responded. And so that's actually very promising and certainly has led to further study in selinexor. A couple of interesting things about this is that the toxicity that was seen with in the previous STORM study, the gastrointestinal toxicity, was not seen. And so, or certainly not seen to the same degree. It was much better tolerated. So there's some sort of protective effect by combining it with bortezomib. There was another study as well, another Canadian-led study, abstract 3330, that was presented by Dr. Christine Chun from Toronto. That looked at selinexor, so the same drug, in combination with Pomalyst. Smaller numbers, 11 patients reported so far, but the overall response rate was 60%. And so we're seeing quite impressive response rates in small numbers of patients, but multiply treated patients, multiply treated patients, good response rates to selinexor in combination with backbone treatments. The other winner, that's probably not a good term to use, but exciting drug in myeloma was venetoclax. And venetoclax is a BCL2 inhibitor that induces cell death in multiple myeloma cell lines, and particularly patients who have translocation 1114. This is something that we look at in various patients, and it's quite a common mutation in myeloma. And venetoclax, there's more research. It's been more studied in some of the lymphoma type disorders. So this study was actually 66 patients of venetoclax, and there was 30 in the dose escalation part, the phase 1, to determine what the maximum dose was, and 36 in the safety expansion, so 66 patients total. And this was venetoclax alone. And these patients were also heavily pretreated, an average of 5 prior treatments. range there 1 to 15. That's a lot of treatment. And the overall response rate there was 21%, so actually quite similar to selinexor in terms of promise. And there were other studies as well. Dr. Maho presented abstract number 975, which was venetoclax in combination with Velcade, and there's suggestion there of synergy, so ways these drugs can work together. One of the interesting take-home points there is if you actually separate out the patients who have this translocation or this mutation in myeloma, the response rate is quite a bit better. So 40% in people with this translocation versus 6% in patients without the translocation. This is everybody. So this leads us again or lends support to using risk or genetic adapted therapy in myeloma in situations where we have a known mutation with a known drug where it makes sense that the drug would work in that mutation. So this was a promising drug as well. And then pembrolizumab was the last new drug I wanted to mention, which is a PD-1 blocking antibody. PD-1 stands for programmed cell death, and it's felt that this drug helps manipulate the immune system. And this was a phase 2 trial of pembrolizumab that in combination with pomalidomide and dexamethasone, so that's a standard treatment for relapsed myeloma. Average was 3 prior lines, and the response rate was about 50%. And the progression-free survival is 10 months, and that's important. So when we look at pomalidomide alone, pomalidomide and dexamethasone alone, the response rate is only about 4 months. When you add cyclophosphamide, it's about 9 months, and pembrolizumab, it seems a bit better. So this drug is actually showing promising activity in myeloma and very acceptable safety profile. And there's ongoing research studies of pembrolizumab looking at it in earlier stages of the illness as well. And lastly, I wanted to talk about CAR T cells briefly, and this is one of the questions that we get asked a lot. CAR T cells have shown quite promising activity in leukemias, particularly ALL or lymphoblastic leukemia. And so the drive has been to evaluate it or to look at it in patients with myeloma as well. So CAR T cells are basically a way that we manipulate the body's own immune system to fight cancer. So what happens is, much like when patients have a stem cell transplant, we do what's called leukapheresis, so remove stem cells from the patient's blood. And then the T cells, which are a type of immune cells, are genetically engineered to make surface receptors, so on the surface of the cell, called chimeric antigen receptors, or CARs. That stands for chimeric antigen receptor. And these receptors are genetically engineered to recognize a specific protein on tumor cells. What happens then in the lab is that the population is expanded, and so we grow these cells in the lab until they reach the billions. And then those genetically modified immune cells from the patient are put back in the patient. And the goal, or the theory at least, is when they go back into the patient, they multiply and multiply in the patient's body, and they have guidance because this receptor is engineered against the cancer cells. That is the patient's own engineered T cells that then go attack the cancer. And that's how CAR T cells work. And there was a study looking at CAR T cells in myeloma patients. And so this was just a pilot trial, so very small numbers, and it looked at CTL 109, which is autologous T cells, so CAR T cells using what's called a lentiviral vector. So that's basically a way of delivering the message to the T cells. And this was used in patients who had had a second autologous transplant. So these were relapsed myeloma patients who did not have a good response after the first transplant, and then were having a second autologous stem cell transplant. And what they did is they underwent the transplantation, and after the transplantation, the CAR T cells were given back. They had 12 patients who were signed up. In one of the patients, they weren't able to grow enough T cells, and another decided on alternate therapy, and 10 went through with treatment. The average or median was 6 prior treatments, and the median progression-free survival was 185 days, so just about 6 months, and all subjects had progressed. But we have to remember that these patients had quite aggressive disease, so a short remission after first autotransplant and already had 6 prior treatments. So 6 months of remission is actually not bad for a new technology. There were no deaths, and so the conclusion was that this technology is safe, feasible, and has led to ongoing research in this technology in multiple myeloma. And I wanted to end with one slide that was presented by Dr. Fonseca from Mayo Clinic in Scottsdale that looked at survival of myeloma patients over cohorts, and the future is bright in myeloma. And so if you look at this trial, and this is compared to the general population on top, patients who were diagnosed with myeloma in 2006, 2007, as compared to diagnosed in 2007, 2008, as compared to diagnosed in 2010 and 2012, we can see that the survival, the probability of patients being alive is increasing impressively every couple of years. And obviously our goal is to have it so that it's either cured or no difference in survival than the average person. But you can imagine with the increases here, can you imagine what the curve will look like when we have data from patients who were diagnosed in 2016, 2017? And so I think the future is bright. I think there's a lot exciting that's happening, and I think we have good reason for optimism moving forward. So with that, I will stop talking. I know Michelle is going to be collecting some questions, and I'm happy to answer as many questions as I can for now. And thank you.
Well, I guess I'll wait a couple minutes and get a few questions coming in. And I want to thank you again. That was highly interesting, I think, on behalf of all the attendees here tonight who unfortunately can't speak out loud. I think we've all learned a whole lot tonight, highly interesting. And I think we can all take away that, you know, like you said, the future is bright and there's a lot of great progress coming in the very, very near future.
Great.
So I don't have any questions yet. So perhaps I can ask you myself. Of course, we have the selinexor trial happening at the moment, but are there any other trials available, I guess, in centers across Canada that patients can have access to that wouldn't be what we consider standard care?
Yeah, so there's quite a few studies available, and that does vary from center to center. So the MCRN, for example, there's 21 centers in Canada that have trials open. I think the trials of most interest are access to drugs that we don't otherwise have ready access to, like you were saying. So in newly diagnosed patients, there are trials available looking at carfilzomib in that setting, daratumumab in that setting. And then in relapsed patients, there are trials again looking at carfilzomib, daratumumab, selinexor, and some of the other new drugs that I talked about, like venetoclax and pembrolizumab, that are coming. And there will be more coming actually in the near future. So I think the trials are out there. It does vary from center to center, depending on what the population is like in each area. But I encourage people to get involved in clinical trials because we're looking for the next best thing. And so it's a way right now of accessing new treatments that we might not have access to otherwise.
Great, thank you for that. Somebody's just asking if you can actually just go back one slide, so they just want to have a look at it. There you go. Okay.
Easiest question of the night.
Yeah. Another question was whether or not this will be recorded. Of course, everyone who's listening, this presentation is being recorded. It will be up on the Myeloma Canada YouTube channel tomorrow. So, someone who's asking here, hello, I have been in remission for almost 3 years. Do I want to try and venture into MRD testing, or do I want to know?
So that's a $1 million and a great question. My advice to you would be no, and the reason being that the first, we don't know the best way to measure MRD, and we really don't know what to do with people in your situation with their MRD status. Nobody's looked at that before, at least to my knowledge. And so when you have somebody who's been in remission for 3 years, what does it mean to randomly check for MRD? So we won't know what to do with the information. And unless so we won't know to do with it. That's problem number one. The second problem is that assuming you were MRD positive, that may cause some anxiety. You're also in a situation where we don't know what to do when you can't do anything about it, uh, save for paying out of pocket, because it's not a reason for treatment, nor should it be because it's not well studied. I think the only benefit would be that it might provide reassurance. But if this was me, or my mom or my dad, I would absolutely not check.
Okay, thank you. In the slide that we're looking at right now, there's a line drop between, well, in the 2010, 2012. Is there a reason
Yes.
for that?
Yeah, that's just because of the time. So if you look at that, the survival in years is at the bottom. So right where that line drops is just before 6 years. And so these are patients who were diagnosed in 2010 and 2012. And since we just finished 2016, we don't know what happens at years 7, 8, 9, and 10. So it's just the end of the follow-up period. It's not because a bunch of patients actually suddenly passed away. It's just the follow-up time is too short. Does that make sense?
Yep.
Okay.
Well, two anyway. Um, what is the quality of life for maintenance therapy after a stem cell transplant?
So that's a really good question. I cannot recall seeing any specific abstracts looking at that at ASH, although again, in the 800 there could have been one buried. Um, the research that has been done so far suggests that there's no difference in quality of life, but there's not really standard validated tools to look at that in the context of myeloma quite yet. Um, the the studies that are published suggest no difference. Um, I think you have to remember that an average of 1 in 5 stops because of toxicity, so there is some impairment there. There's recently been a study done by the company that makes Revlimid Celgene to address this question exactly and to look at patients who have been on maintenance for several years versus not. So long and short of it is there's more data coming. The research available suggests there's no difference. About 1 in 5 patients does stop because of toxicity. And so it's hard to know um, with certainty.
Great, thank you. Is maintenance an option after 1 year of stem cell transplant? I received a good partial remission, which continues.
Yeah, so that's a great question. And it's a hard question because, there's a whole group of patients out there who had transplants before maintenance was available. And we don't know what if you were to start maintenance 1 year or 2 years or 3 years or 4 years after a transplant, we don't know if that carries the same benefit that's been seen in patients who have it immediately following a transplant. Very likely it's an option. Um, it's I've actually in that situation never challenged the provincial payers to as to whether or not they would approve it in that setting, but in theory it's an option. I think again risks and benefits you'd have to weigh. Hard to know exactly how that fits in because it's not specifically been studied to my knowledge. And when lenalidomide is used in maintenance, it doesn't work as well as relapse. Um, Again, the burden of evidence is looking like that doesn't matter as much with respect to at least PFS data, but you're sort of taking it off the table in a way. And so I think it's a possibility. I think whether or not it's the right thing to do, there isn't data to support either way. I think it's a good question to talk to your hematologist about your specific case and whether or not you think it might be of benefit to you.
Okay. I think here's a question that many people kind of struggle with at home. Well, or have the same question. So my father was diagnosed with MM in April 2013. He has many treatments. He's had many treatments, including a autologous stem cell transplant. He's currently on Darzalex and Pomalyst. We don't have the results yet, but he's currently experiencing fluctuating fevers. Does this mean that the treatment is not working?
No, it it's not necessarily. It can. So certainly, active myeloma can cause fevers, but both Pomalyst and daratumumab can also cause fever. And so it could be related to myeloma, but it could very much also be related to the treatment. And so I think it's reasonable to be looking into it, but it not reason to panic and think that it means the treatments aren't working.
Okay, thank you. I think this is also a question that most people are hoping for a positive answer for. Are you aware of any studies looking at steroid-free protocols?
Uh, it's a great question. Um, to my knowledge, in the Canadian landscape, there aren't any studies, certainly in newly diagnosed or relapse treatment that is, second or third relapse. When new drugs come through, so for example, venetoclax, like we talked about, they're often studied as single agents, but those are typically for patients who have multiply refractory disease. On average, the number I usually say is that steroids increase the efficacy of a drug by about 20%. And the reason steroids are used is because it makes the drug work better. And so they're part of the backbone in virtually all treatments. But I can appreciate where patients would absolutely be wanting steroid-free options or an alternative to steroids. But as of right now, they're quite deeply infiltrated unless it's the single agent setting, and that's typically for multiply relapsed or refractory patients.
Okay, and I saved the best for last. So
Okay.
if you had to pick one, what therapy or trial at ASH excited you the most?
Oh,
Is
that's a
it not
great
easy?
question. Yeah, that's really hard. I mean, I think, to be honest, I think there's a couple of things I'm just sort of flipping back through slides. So I think there's a couple things that really excited me. One was this study actually, which was risk adapted treatment, or sorry, not risk, I've talked about that for a long time, is response adapted treatment. So so there's now data to support that modifying treatment based on response in individual patients is maybe a good thing or likely a good thing. The other response adapted therapy that I didn't present today but has been studied is looking at stopping treatment in patients who achieve MRD negativity after a transplant while they're on maintenance. So the ability to actually give patients breaks from treatment if they achieve deep remissions. And so the reason that's exciting to me is I don't know if any of my patients are out there, but I talk a lot about risk adapted therapy. It's hard to do in our setting, but tailoring treatment I think is of paramount importance. And so when we're now looking at using response adapted therapy, so again, personalized treatment, and either intensifying or reducing treatment based on individual patient responses, that to me is really exciting. And we're moving to this era where drugs we're using more drugs and combinations and more intense treatments, and those numbers are promising, but indefinite treatment I think can be quite hard, and many patients are wanting to have a break at some point. And so being able to use more intense treatments with the goal of actually adapting that response and giving patients time where they're free from treatment and in remission is really quite exciting. So I kind of cheated, and that's two different things, but it's response adapted treatment and the movement towards personalized myeloma care that has me the most excited.
Right. And I know we're nearing the end here, but two more excellent questions just came through. So I think after these two, if there's any more questions, you can feel free to email us at Myeloma Canada. So either the email that was provided to you when you signed up, which is my email, moana@myeloma.ca, or you can always contact us at contact@myeloma.ca, and we'll be sure to get to any more questions that come through. So again, so for the last two, whatever happened to the measles virus treatment?
Yes, the measles virus treatment is still being investigated. as far as I know, being done at one or two centers in the US. To my knowledge, there was no update at this ASH in myeloma, and so I don't think it's done yet, but it's not been done. Sorry, I don't mean it's sort of gone by the wayside, but it hasn't been studied in large groups of patients, and I don't think we truly know what its utility is going to be. But I haven't seen an update in quite some time, to be honest.
Mhm. Okay, thank you. And finally, wasn't daratumumab rejected for reimbursement by PCODER, and how would patients access daratumumab otherwise?
Yeah, so daratumumab was recently rejected because of cost effectiveness, and it's challenging because it's come through a couple times as a single agent and other. The reality is that in the Canadian setting, it's given once a week for the first two cycles, so 8 weeks, and the cost of daratumumab is $27,000 a month. And it's very difficult for the public system to support that in combination with other drugs that are about $10,000 a month. So that doesn't mean that daratumumab isn't coming. They're going to have to work on the cost effectiveness and also at using it in its most effective capacity. So not as a single agent, but in combination with other drugs. So I certainly have not given up hope that it will be publicly funded. Right now, it's available either on a compassionate access program in patients who have multiply refractory disease or in the setting of clinical trials, but
I
it is
will,
not publicly funded.
sorry, I totally didn't mean to cut you off
It's
there.
okay. Yeah,
I just wanted to add to that to say that we do have some exciting news for the MCRN, that we do have a trial coming
we
hopefully
do.
this year,
Yes. Yeah,
which will include daratumumab, so that will be one way to access the drug. So we will have some more information on our newsletter coming out this month. So stay tuned for that. So it should be, yeah, opening sometime this summer or in the fall.
perfect. Yep.
Great, and I think that's all. So of course, we'd like to thank you again for taking the time this evening away from your family with us. We certainly appreciate all of the exciting knowledge that you provided us tonight. It was highly, highly informational, and I think we, we're all leaving very hopeful, I should say.
Great. Good. Thanks, everybody. Thanks for listening.
And we'll talk to you soon. So have a good evening, everyone.